Thank you. So it's with great pleasure that I introduce the two medical students that are going to be presenting for us today, Paula Goldman and Erica Prochaska. I want to emphasize that Paula and Erica came to us last year and were interested in working in Ecuador, in Quito, Ecuador. They're part of a larger enterprise within the medical school called the Quito Project. Quito Project started a number of years ago by an enterprising student who set upon to go to Quito, Ecuador, and work in the health community there, both at an educational level and an assessment, monitoring illnesses, and teaching individuals about healthcare. So both Paula and Erica, they talked to us about their project, and then they set about and they wrote up an application for a funding source, because as you know, funding is very short, and we're all in need of identifying additional resources. So we don't have resources just to say when a student comes and asks us for a project, well, here's a project and here is the money to do it. So we had a couple of conversations about the nature and the extent of the project, and they took to that with a passion and an energy that will be reflected in their talk now. But they applied for funding for this project, and they were awarded funding for this project. So they are well on their way, or are on their way to becoming independent investigators. And so they spent time in Quito, around 7 weeks there, gathering data that they're going to be talking to us about, and performed extraordinarily well and learned a lot. And we're so delighted that this project could be part of their training, and we're just excited to hear about what you guys did. So Paula and Erica, please come and I will get your project now. Now, does one of you want to use this, or do you want to just stand with the microphone here? So they're going to be doing this in tag team, so yeah.
We can switch back and forth. That's fine.
That's totally fine.
That's how we designed it.
Okay, that works. All right. Hi, I'm Paula Goldman, and this is Erica Prochaska. And as Dr. McGinnis mentioned, we're both second-year medical students right now at Michigan. And this summer, we had the opportunity to go work together at a cancer hospital in Quito, Ecuador, under the mentorship of Dr. McGinnis and also Dr. Sophia Mariver, who's an oncologist. And we're here today mostly just to share the insights that we gained from this incredible opportunity to study the psychiatric challenges faced by those cancer patients, and also to learn experientially about how tablet technology can be useful in improving access to psychiatric care. So what need are we addressing? This project arose, I guess, most fundamentally out of a need for greater attention to psychiatric well-being. But we're all aware that that need is by no means restricted only to the population of cancer patients, nor only to the location of Quito. So to put this into context, depression currently affects over 150 million worldwide and is the third greatest contributor to global disease burden. However, this burden is disproportionately borne by those with chronic disease, and specifically cancer. Studies to date have found that cancer patients suffer from depression at a rate of at least 25% and maybe as high as 50%. And this depression has a really key role in their quality of life from the time of their diagnosis on. And while that might seem intuitive, it's really important to appreciate how significant that is in a medical context in which often quality rather than quantity of life is going to become your treatment goal. But even beyond that, there are really real impacts of depression on the quantitative outcomes of cancer patients as well. A meta-analysis of 76 studies found that consistently the amount of depression that a patient is exhibiting will predict the progression of their cancer and the likelihood that they will die from their cancer. And so in addressing depression in this population, I think we feel that's something that's really important to look at is the really strong role of interpersonal relationships and support in helping people to cope with this diagnosis. Among cancer patients suffering from depression, the most commonly cited reason for feeling depressed is actually not their prognosis and is not about their pain. It's about the degree to which they feel supported, and specifically if they feel that they have problems or deficits in their interpersonal relationships. This perceived lack of social support is very tightly associated with who will develop depression and who will not. And this association is even stronger when you look at social support more narrowly, as the support that people get from their closest and most trusted relationships, or in many cases you can narrow it down even just to their partner. And many studies already to this point have shown that support has a really influential role by having interventions that target exactly that, augmenting support. And the results of these studies show that not only does this improve pain, depression, anxiety, it also improves mortality. So then this brings us to the question, why were we in Quito in particular? And why were we looking at this particular group of cancer patients? And I think that starts with the largest question, so why South America? And part of that is based in need. There is, in fact, a near absence of research on depression in these particular cancer patients. So far, there's almost exclusively data on European or North American patients. And then also, in Latin American systems thus far, there isn't a very developed integrated approach to mental health care with cancer care or with other types of chronic care. And so there is a need. However, we know that there's need the world over. And one of the reasons we were really interested in South America in particular is because it has this really unique cultural context also, in which we can look at things like mental health and depression. And so some components of this that are interesting is, for example, in cultures such as Ecuador, it's very common to place an extremely high value on family ties, on one's relationship, on one's role in the community. And so we were interested to see if this also meant that your social support would have a greater impact, therefore, on your mental health if you value it more in your particular culture. And then another thing that's really interesting to look at about this is that there's a lot of stigma still surrounding mental health issues in South America, and that largely comes from the fact, which we got to see firsthand, that mental health and spiritual health are considered to be very, very much intertwined. So when someone's struggling with their mental health, that's often attributed to a failure in their faith. And so these are some things that we were really found interesting to look at. So now we've got why South America, so why Quito in particular? And there's a couple reasons for that. One reason was that we were very fortunate to have some former work to build on. So we have the work of a current third-year student named David Schrock the year before, and he used the same depression screening tools to go out in the primary care setting and see what the prevalence of depression was, and also he was able to do a lot of key things for us, such as validate the tool we were going to use, validate that, or confirm that the translation to Spanish would be appropriate for Quito in particular. And also, he was very successful in using tablets to deliver that, which was helpful for us designing our methods as well. And so, within Quito, then, you come to the particular hospital we worked at, which you saw in the first slide, which is referred to as Solca. And Solca is a really unique place for us to have conducted this research because it has a uniquely combined private-public model, which is made possible by the fact that the quality of care there is so high that although it was designed to be and provide to the public sphere, those with private insurance also willingly choose to go there. And so for that reason, we got to see while we were there a wide range of socioeconomic classes. People were coming from great distances to get treatment at Solca. And so it was a uniquely representative cross-section of what Ecuadorian society looks like. So that was extremely beneficial to our understanding, I think. What's more, we also had, I want to recognize real quickly, that we also benefited at Solca from a very incredible mentor, Jose Mosquera, who was very anxious to have us, which is a very unique experience, perhaps an international relations that he really wanted to have us there because just him and his one resident are responsible for all the psychiatric care for this entire cancer hospital. So with all the time that they devote to their clinical responsibilities, they certainly don't have time beyond that to get to do the big picture research that we were able to supply for them. So for those reasons, we ended up in Quito.
So Paula just did a fantastic job of giving you the overview of what we were going to look at and why we chose to go to Quito. Now I'm going to delve into a little bit more detail about what our research questions were and how we decided to pursue answering those. And to just give you a little bit of disclaimer, we haven't answered all of these yet because we're still looking at our data. We're going to fill you in on what we have looked at so far. So first and the most broad question is, what is the incidence of depression and distress in the Quito cancer patient population? We had 3 surveys to assess this, which I'll go into a little bit more detail on the next slide. And then we wanted to look into more depth about how are depression and distress related to social support. This is extremely important in Latin America for the reasons that Paula mentioned earlier. Social support has been shown both quantitatively and qualitatively to be very significant to healthcare among Latin Americans. There's other reasons that social support is particularly important among cancer patients. One of those reasons is that interventions such as support groups have been shown to be more effective among patients who have low perceived social support, especially among breast cancer patients, who are some of the most, at least in the United States and Europe, where a lot of these studies have been done, breast cancer patients have some of the highest rates of depression. So that's one reason that we really wanted to look at social support, not only amongst the whole population, but also amongst certain groups. Which brings me to the third point, is which groups are at highest risk for depression, distress, and perceived low social support? This is the really hard question to answer, and we haven't gone into all of the data yet. We certainly have some theories about people who are going to be at the highest risk for depression. Patients who have low social support have already been shown to have that, which we'll talk about a little bit more later. But what we're specifically going to do with demographics is look at cancer diagnosis, level of education, how far they're coming to get their care, whether or not they're from Quito, for example. And we really believe that these things are going to be important for directing interventions in SOLCA. We hope that the next part of our research is going to be the intervention stage, how we can help Dr. Jose Mosquera and his resident actually address the underserved population that they're working with. And we believe that first we need to identify who is at highest risk, because they're serving so many patients that it would just be impossible to give everyone the same intervention. And then these are the surveys that I referenced earlier. We used the Patient Health Questionnaire 9, which I'm sure many of you are familiar with. It's a very, very common screener for depression that's used in the healthcare setting. It's also what David Schrock, who is the third-year medical student who went to Quito in 2012, validated in the primary health population. We used the same exact version that he used. We didn't alter any of the language or the Spanish. Then we have the distress thermometer. This is a really awesome screener for the oncology patient population because it's so simple. It's, as you can see, this is in Spanish, but there's different emotions and then a thermometer, 0 being none, 10 being the most, the only difference being need for help, which is you need it desperately, or you can resolve everything on your own, being 0. And that worked really well as well in this population because it's very easy to translate 0 to 10. And And then finally, the estimates of close relationships. This has been validated in Spanish, but the catch is it was validated in Spain, which is very different than Latin America. Although we had the Spanish, and we also had individual validations for each question on the estimates of close relationships, we weren't entirely sure how this was going to work out in Quito. We'll talk a little bit about that more later. And then also the estimates of close relationships is for patients who have an intimate partner. And not all of our patients did have an intimate partner. Because each question was individually validated, we were able to make a mini ECR for patients who did not have an intimate partner, which was significantly shorter. And then finally, we used this software called PollDaddy on all of the iPads to collect this information. It worked really well because patients would just fill out the surveys on the iPad. It would get stored on the iPad in a hospital with no Wi-Fi. Then we would go to the hostel that we were living in. if they had Wi-Fi that day, which was variable, we would be able to upload everything to a cloud server, which we still have access to. So it completely limited the need for data entry, which I think anyone in research can tell you is pretty incredible. And then this is now getting into our results. Paula is going to describe a little bit about who our patients were and who we were interviewing during this research.
Thank you. All right, so we ended up having the opportunity to interview over 300 patients, which was really exciting. And we found that their average age was about 54 years, and the gender breakdown was about 2/3 women and 1/3 men. And so some of the things that we saw, for example, was with ethnicity, we found that 84% identified as mixed ethnicity. To a large extent, this was a mix between indigenous and white. And so that was actually very close to national census data, which identifies about 80% of the population in that way. So that was great. With some of the subgroups, there was a little bit of difference. And so for Afro-Ecuadorians and also for indigenous people, those groups were a little bit underrepresented, while white Ecuadorians were a little bit overrepresented. And that might be in part because of the difficulty for indigenous peoples to use the iPad technology, which we'll talk a little bit about later. Also, the education was very variable, which is again a reflection of the fact that this is both private and public. So we've got about 23% who had primary education or less. We've got about 40% who had secondary or technical training, and then 37% who had something beyond secondary education. And employment was also very variable, which I encourage you to take a look at. But the things that we noted that were important was that 1/3 of the people that we interviewed actually identified as housewife, and that's actually half of the women that we looked at. And also of note is that the unemployment in our group was self-identified at about 11%. So also important to look at is what kind of cancer exactly were we looking at? Because previous literature has shown differences between the different types and how likely you are to have depression. So we've got an enormous amount of breast cancer patients, about 80 overall out of about 300. And so that might be overrepresented, but keep in mind two things. One, we already have women overrepresented, so that's part of the explanation. But then also, Solca is very well known, especially for excellence in breast cancer care, even beyond Ecuador. So those are a couple reasons you might see that. GI is actually second, which might be surprising, but is very consistent with other findings in South America. And there's a lot of research going on right now to come up with a really substantiated explanation for that. Likely has to do with both diet and also the composition of the soil and how that's affecting what people consume. Something else that's interesting that we saw is that there are only 22 prostate cancer patients, which seems very, very low, and seems in fact lower than you can explain simply by the fact that men are underrepresented to begin with. And we think that part of this has to do with the fact that screening is a little bit indefinite at this point in their primary care practices. We know that for sure in cervical cancer patients that that's the case. But also our colleague who was working with us, who's an Ecuadorian student, suggested that this might be because of men's reluctance to come forward for treatment due to the integral role of their feeling of virility in their male identity, and therefore being concerned that any kind of treatment they would receive could potentially threaten that. All right, so our results. As we mentioned, we have not broken this down as far as we would like to, but these are our very most basic and also very important findings. For one, overall, those that we found, it was about a rate of 24.6% having a very high level of depression, which is interestingly actually on the very low end of what's been found in previous literature. You can see right here the breakdown for both men and women. And then we did find, as we were expecting, that having a high level of depression was significantly associated with a high level of distress. And as we thought, a high level of depression was significantly associated with low social support. However, the interesting thing was that this was only true for those patients who identified having an intimate partner. There was no relationship found between depression and social support for those without an intimate partner, which is interesting. When we think about this, we think that perhaps those who have an intimate partner For them, their interpersonal relationships and their reliance on that partner has a more crucial role in the coping processes that they have developed. But of course, that's hard to be sure. And then as we move forward, as Erica mentioned, what we want to look at is what specific groups have the strongest relationships between these different factors, which particular groups are the most likely to have low social support and be in need of more, and which groups are more likely to show depression.
Given that the topic of this conference is about the interface between technology and mental health, I wanted to talk a little bit about our experience using iPads with this population. David Schrock showed in 2012 that iPads worked extremely well in the primary care patient population, and we largely found the same thing. The difference between our patients and the patients that David was working with is ours were a lot more diverse, both in where they had come from and also how ill they were feeling at the time that they were using the iPads, which did change patients' abilities to interact with the technology. So most patients loved using the iPads. I had a woman tell me that she was going to go out and buy an iPad so she could play with her grandchildren. Especially a lot of the older patients, really liked that they could get what their grandchildren were so excited about once they finally used an iPad. Patients even came up to us sometimes and said that they wanted to do the study just so they could use an iPad, in which we had to, back up and be like, all right, this is not an incentive. You can use the iPad, we can show you how it works, and you don't have to do the study, just to make sure that no one felt like they were getting an extra bonus from participating in the research. But of course, we did have patients who were extremely ill, especially patients who were undergoing chemotherapy and radiation treatment, had a lot of side effects that could affect their ability to use this technology, such as loss of sensation or tremors. We also had some very elderly patients who had difficulty seeing the tablet and interacting with the technology just conceptually. And those who had a low level of education also really struggled with the technology, not just reading, but comprehending what was happening and what they should be doing. One thing that we also could not provide is a version translated to Quechua, which is the indigenous language in this area. But there's two reasons that would have actually probably not changed our research population that much. One is there's lots of different dialects of Quechua. Quechua is a language family, but Quechua varies a lot. And also many people who only speak Quechua probably aren't literate. So using a written survey probably is not going to capture those patients anyway. Another great thing about using tablet technology is that patients can hold it and use it and interact with it and share it with people as much as they want. Confidentiality is very, very different in Latin America. Psychiatrists see whole families when they're doing a mental health consult. They don't just see the patient. And some patients wanted to do this survey with their family members. They wanted their son or their daughter to give input, like, oh, how has my appetite been? How have I been sleeping? And then sometimes people just wanted to take it and look at it and go in a corner and do it by themselves and didn't even really want us looking at it. And that's fine, but the tablet mobility allows patients to do that. And then finally, as I mentioned before, the data collection was super efficient and very secure using this technology. There was no chance of us losing a paper survey anywhere with someone's results on it. Now, Paula already did a fantastic job of reviewing what our results were. Although we are on the lower end of the spectrum from 25% to 50% of cancer patients have depression, we're on the lower end of that, but still 25% is a huge amount of patients. And you also have to consider that we probably lost some very ill patients given the fact that we were using tablet technology. So we might even be on the lower end of what's true at SOLCA. So depression is very significant, and especially among those with elevated distress and low perceived social support. That seems very intuitive. No surprises there. And iPads, as I mentioned a couple times, are very effective in this population. They decrease research labor and therefore would decrease clinical labor as well in trying to get people help and resources that they need. But unfortunately, comfort and ability to use iPads varies widely, which could also keep some people who really need help from getting it. The distress thermometer and the PHQ-9, in our experience, worked extremely well. Patients understood the questions. They needed a little bit of guidance sometimes with understanding what they were supposed to be doing with answering surveys, because it's not as common there to do when you go to a doctor's office. But once they got the pattern down, they really were great. The estimates of close relationships needs to be tweaked a little bit to be more culturally appropriate for Ecuador. There were some inconsistencies between the Spain Spanish and the Ecuadorian Spanish, and patients were confused sometimes. We also are not entirely sure if the findings that Paula described a couple slides ago about intimate partners versus patients who don't have intimate partners is due to the fact that patients who do not have intimate partners do not experience low perceived social support, or if the problem is that our shortened version, which did not include any mention of intimate partners, wasn't as effective as capturing a perceived low social support. So we need to revisit that question and try to figure out what's going on there. And where do we go from here? Well, what we're going to do this year is determine which groups of patients are at highest risk for depression, distress, and low social support, with the goal of then creating support groups. Support groups are really fantastic option in this case because they're so low cost, and also, as I mentioned, confidentiality is just entirely different in Latin America. A lot of patients that we worked with were already working with each other to talk about their issues that they were experiencing. Sometimes I would go up to a group of women and I would think that they were sisters, and I would ask, how are you related? And they're like, oh, we're all friends, we're all patients here. But they saw each other every day, whether they're getting chemotherapy together, seeing the same doctors, and they talk about their experiences. And it's a very, very powerful connection. And it's so unusual for patients to be that open in our culture about what they're going through that we both think that it would be a very natural transition to have an organized support group. We need to consolidate our screening tools. Right now, it takes about if someone's super fast and super literate, they can do it in 10 minutes, but it can take up to 45 minutes to do all these surveys, and that's very wearing, especially on patients who are going through a lot emotionally, because these surveys, bring a lot of stuff up that they might need to also talk about afterwards. And then expanding to other patient populations. SOLCA is very unique, as Paula mentioned earlier. It's part foundation, part government funding. It can charge on a sliding scale. Still, there's people who can't afford that sliding scale. They go to public hospitals. Those are the poorest of the poor, and we really have no idea what those patients are going through. There's also private hospitals where there's much more individualized care. We don't really know what that population is like either. And we're also extremely curious about the cancer screening population. The cancer screening population is of interest to us for the reason that Paula mentioned, with cervical cancer screening and prostate cancer screening not being as successful as we would anticipate, given that recently Ecuador has undergone a public health care revolution. And as such, there's a lot of government subsidies for screening, but still people aren't going out and getting screening done. Qualitative studies in Latin America have shown that women are very, very anxious about getting screened for breast cancer and cervical cancer. We would like to have some sort of quantitative way of measuring what are people feeling when they go in to get a mammogram, a pap smear, a PSA, and then what can we do to ameliorate that so that people are taking advantage of these services and getting the care that they need before their cancer has metastasized. And now these slides should actually have been called What We Took from This Experience, because Paula and I are going to talk more about what we both experienced, but just different sides of it. So I'm going to start a little bit more general, and then Paula's going to go more specific. So what we took from this experience, I think Paula and I were both extremely nervous about going in and working with patients who were terminally ill and asking them about depression and asking them about their families and how potentially their marriage had even fallen apart once they were diagnosed with cancer. But what we both found is that patients vary incredibly in terms of not only how they see their diagnosis, but also their treatment and their depression and how they want to deal with those and talk to you about those things. We both learned that even though we use the phrase cancer patients to describe our research, there are no cancer patients. There's human beings who have a diagnosis of cancer. And each person is going to handle that differently. I talked to people who had had a thyroid removed due to thyroid cancer, had not metastasized anywhere, had a fantastic prognosis, but they were in a bad place because they were going through all these hormonal swings from having a very big part of their endocrine system removed. And that was real for them. And then I also talked to patients who had metastasized cancer, who had a very, very bad prognosis, who were really happy and really peaceful and said, I am happy with what God gave me in terms of my life, my family, my job. I'm ready to go whenever He's ready to take me. And I learned that I can't go to a patient and think, okay, this person is clearly going through chemotherapy, has clearly had a recent operation. I should feel bad for them because they're probably really sad. That's not the case. Someone's going to feel however they're going to feel that day about their illness. And I think that's really going to help both of us going into our third year to treat every single patient as an individual and not as their diagnosis. And then just in case you're curious, this is an indigenous market on the way to Quito, which is a crater lake in Ecuador. And if any of you get a chance to go, you should, because it's beautiful.
All right, and to touch on a little bit more about what are those concrete benefits that we get to enjoy from having had this experience. I think as developing researchers, this was a really powerful experience in starting very much from the ground up and having to build rapport and develop shared goals across considerable cultural barriers and also something of a language barrier. And I think it really helped that we were forced, because this was our second language, to do this whole thing in a very reflective way. We really had to plan out exactly what we needed to communicate ahead of time. We really had to ask a lot of questions along the way to be absolutely sure we understood what others were trying to communicate to us. And we really had to establish priorities for what needed to get interchanged between the different stakeholders. So I think that that was really powerful for us. And I also think that our development as clinicians was enormous during this particular experience. I think part of that comes from the fact that this was a very unique setting in which we could spend unlimited amounts of time with each patient. We really could. We could sit there for as long as they needed us. And that's really something unique. I might never get to do that again. And so this is something that I think we're both really grateful for. And I think also beyond that, this was a really great way for us to develop our skills in being present to someone else in really, really tough times that we have maybe not otherwise seen. Right after someone has received bad news, for example, right when someone might have had a big change in their relationships as a result of what they're going through, or even dealing with some patients who really mistrust the system because of what they've dealt with in the past in their cancer process. And so it was really important, I think, for us to get to do this without having the burden of the outcomes and the treatments being our responsibility, because it's not. We didn't have to fix it. We could just practice learning how to receive that in a really constructive and professional way. So we'd just like to thank our very big team who helped get us there, and especially Dr. McGinnis and Dr. Mariver, who's not here today, who are our two U of M mentors. And our entire Ecuador team is up here as well. And we would love to take any questions that you have.
Thank you very much for a wonderful presentation. And so now we're open for some questions.
I'm curious about your survey itself. Did you ask people if they were on an antidepressant already and or seeing a psychiatrist or primary care doctor? Was that one of the questions?
It was one of the questions
Okay.
during our demographics.
Okay.
At the back there, Jamie.
Yeah, I think using the PHQ-9 is tricky in this population because we have some questions that are going to pick up on physical problems that people are having, and I wonder how you're dealing with that.
Could you repeat the question for the people that
So the question was, or the comment was, that it's very difficult to use the PHQ-9 in this population because there's a lot of side effects from cancer and cancer treatment, which are also mentioned in the PHQ-9. For those of you who are maybe less familiar with this survey, one is changes in sleep, another one is changes in appetite, which are very common for patients who have cancer.
And I think that part of this was that this was also one of the reasons that we used the distress thermometer to get at a very emotional, a very raw emotional look at these things. And I think that also the PHQ-9, as we're looking through it, what we're very much interested in all of these cases is coming up with a final tool that's very much consolidated. So we will be going through item by item to figure out which of these items were working for us, which weren't, what do we believe is getting at the real evidence in this versus what needs to be modified. I think we're still in that process now, though.
Thank you. Yeah, John has a question.
Me? So first, I would like to just personally commend and thank both of you, because I think despite you saying that you really just got a lot of learning and it wasn't your responsibility, I suspect you were very helpful to these individuals as well. Two is I hope you both go into psychiatry. And three is just an additional study that maybe you could add on just from the observations that you have if you kept track of those. It wasn't probably part of your survey. The data, I think, are out there that what you said, generally family supports are very important in terms of how people do in the overall progression of the cancer. And that's been shown in other venues as well. If you had, I'm giving you a hypothesis, if you had observations that some were quite willing to share even the survey process with their family members, I will give you a hypothesis that those people probably had lower distress, lower depression, and if followed over time would probably have better outcomes than the ones who had to go over in the corner and fill it out. So something for you to test. Thank you for what you did and do.
Thank you.
Thank you.
Lady there, yeah.
Adjusting for the fact that you had twice as many women as men, how did depression rates compare between men and women?
Oh, sure. The results. So the distribution was.
Yeah.
Oh, yeah. There you go. I think what we found so far is that the distribution is not particularly dissimilar. There's really not as big of a difference as even we might have thought, but we have not yet broken it down by cancer type, which I think will be really revealing as well. Do you have any thoughts?
Yeah.
If I could jump in, I think you might be asking the usual question of do women have 1.7 times greater rate than men if you take lifetime prevalence? Is that what you may be asking?
Well, I don't know the figures, but yeah, as out.
Generally, women have a higher rate of lifetime onset and course for depression than men. And is that true in Ecuador? I suspect so, but go ahead.
I actually haven't seen any data across Ecuador as a population study on depression. There was David Schrock's study, which was in a very small primary healthcare clinic. So I can't speak to whether or not Ecuador has same trends as the rest of the world. But one thing that we do want to look at in terms of the health information is because we did have such a large breast cancer population, and because breast cancer patients have been shown across all of Europe and the United States to have very high rates of depression, that would be one group who we're particularly interested in looking at, which in breast cancer does not have to be a purely female disease, but in our case with our population, all of the breast cancer patients were women.
Just as a note, the rates of depression in Ecuador are currently really under study. There's no reason to suggest, though, that they're any different than any of the other countries, both in North and South America. I think, John, correct?
Yes, and across all the low and middle income countries in Latin America, women have twice the rates of depression as men.
That's worldwide, by the way, generally. I mean, figures differ a little depending upon who you study and where, but.
You guys briefly mentioned that mental health and spiritual health are considered to be combined. Can you talk a little more about that and maybe what problems you found?
Sure. I think what I was saying was that this was a really powerful phenomenon that, you know, there's a very strong sentiment that your faith gives you strength and you therefore would not have depression. And that's the inference that's made from that, which is in some ways, you know, threatening to the ability of someone to come forward with those issues. And so that's what we were seeing as a really unique cultural component. Did you have a further question, though? Does that explain? Okay.
And one thing that I just wanted to add to that is that there's a very strong belief in destiny and in God's plan. So if patients would often tell me, no, I'm not depressed because I'm a Catholic and I know God has a plan for me. And it's sort of the more anecdotal side of what Paula was just saying, which is if you believe in God and you have faith, then you're not supposed to be scared because you love God and you know God loves you.
Did you have any of the patients that you had there through the clinic have overt problems in the context of either kind of manic episodes or, for lack of a better term, sort of a breakdown in the clinic and sort of a catastrophic reaction, either profound anxiety or that, or because it sounded like people were very well in control of themselves and everything went relatively smoothly. Were there crises that have emerged, I guess, at a mental health level?
There's one particular incident that I think shocked both Paula and I, not because it was particularly different from what we had seen in the United States in terms of energy level, but difference in terms of the way the family reacted. There was one patient who was having a very emotional episode, and it was clearly a large indigenous family who were all circling her in the hallway and all crying and like sharing that same level of energy. Not entirely to the degree of the patient, but clearly it was this very cathartic group process. But that was the moment of kind of uncontrolled emotion that I saw. I wouldn't diagnose it because I, have not become an MD, but I don't think that it was a manic episode. I think that it was just an emotional episode that they were using family to treat rather than going to the psychiatrist.
I have a question.
Yeah.
I've read also something that in some cultures, especially if it's related to their spiritual component, is that they look at it as a punishment and shame, and not looking at it as a punishment from God or from whoever, then that lead to a lot of depression because they don't want to really say something about or talk about it. So I don't know if something came up in your meeting with the patients, or they said something about that, because that seems to be one of the underlying depression that the study that I read about.
I would have to say that in our experience, I could understand very much what that chain of reasoning would be, but I never had anyone tell me that they perceived their disease that way, that they more perceived faith as the way that they were going to get out of this. I didn't see very much evidence of them thinking of the same kind of construct of faith as relating to how they got into the disease. I didn't hear that in particular. Did you ever?
I talked to people who felt very ashamed, like they were abandoning their families by being sick, especially young mothers who had young children. But no one ever expressed it to me as punishment. But that could be because those who felt that way weren't going to tell, someone from the United States that, there's only so much that, you can go across cultural boundaries.
With the overall family support and the low perceived support, do you think it would be beneficial for depression in general in the onset? It would be to focus on custody and parenting rights of people with divorce and separation in their family, where 2/3 of youth suicides are children from single parent homes?
Did you have data on the people that had intimate partners? I think about 2/3 of them were identified themselves as having partners.
Yes, over
Yeah.
2/3.
Because we had, I think, around 1/3, it was about 1/3 that didn't have an intimate partner. Do we know how many of them were single parent? Because I don't know that
I don't know that we know anything about parenting status
No, I don't
in our
think
demographic data.
Yeah,
But it
there's
would be
not much in that field that might be parameter
It
to
does
start
sound
looking
interesting.
at in the big
That we have
picture.
the data.
Yeah. There's a lady behind you in red there that had a question. Maybe pass the microphone. Thank you. Yeah.
I was just wondering if either as part of your research or just anecdotally, you got any information about depression in the family members of the patients who had the cancer.
We did not look at that. It's something that when we were way back thinking about creating this, we had thought about looking at it because it is extremely important across the world, and especially given that we're looking at a country that has such strong familial support. I will say, though, that we started both being approached by mothers of children who were getting treated for cancer, because it just so happened that the psychiatry waiting area was right by the pediatric oncology waiting area. And we kind of, I guess, got labeled as the girls you talk to about your emotions if you're feeling kind of down. And it's definitely something that's not being treated amongst parents. There's absolutely no resource available other than Dr. Mosquera to treat the parents of children who have cancer. And they're not really being told about him. I think we both had to tell mothers of children who are getting treated for cancer that there was a psychiatrist that they could talk to.
Mm-hmm.
So I just think just to thank you all very much for your wonderful presentation, and thanks also to Emily for her talk.